to that to take that into it and take that into account. And also, of course, exercise. I think you guys love exercise, right? Yay! We also
PT.
do, yeah, PT. We also do a ton of oral and nasotracheal suction, and then, of course, trach suction. Now, with our patients who are on ventilators, we do CPT on them, especially the little guys get a lot of CPT, vest, and then we can do IPV in line with the ventilator, or we can actually take them off the ventilator and do the IPV directly to the airway. And cough assist. And of course, we do a lot of early mobility in our kiddos, even if they have ventilators, and then the ET tube suction or trach suction. So we just kind of wanted to touch a little bit about the order that we do our respiratory therapy in. Um, Over the years, we've kind of really developed this and kind of really keyed in to what works best for these patients. So we always want to start with our bronchodilators, and that way they can have their smooth airway muscles relaxed and get ready for the rest of the treatment. Then next, we'll give a mucolytic nebulizer usually, and that gets down in there because we've already opened the airways up. And so the mucolytic's going to go into the airways and start busting up that mucus. Then after the mucolytic is when we do our airway clearance um, technique. And that could be anything from CPT, breathing exercises, um, any kind of vibration, chest, anything we do with that. And then step 4, that's when we give the steroids or inhaled antibiotics because all the mucus will be cleared. So all those maintenance medications can really get in the airways.
Thank you, man. I just want to add, I know in Thailand that PT, you guys don't do the medication. You guys don't administer the medication for this patient, but we put this slide in here just to highlight the importance of actually doing the medication before you do any physiotherapy, any chest therapy. So I know, and correct me if I'm wrong, but I think nurses do most of the medication administration. Um, and I know when I visited Thailand that uh, you guys do a pretty good job like talking to nurse and kind of scheduling the treatment so the nurses can do the inhaled medication before actually doing any kind of therapy because it makes a huge difference. It makes a huge difference if you do a mucolytic prior prior to chest therapy because it loosen up the secretions and then doing the therapy actually you help the secretion come up. So just highlighting that. And this slide um, is just to remind you if you um, see a patient do it or nurses administering the medication to a patient because this is really a crucial technique how patients take the medication that makes a huge difference. So we have here like from shaking and patient exhaling, taking the breath in, it really makes a difference how effective your treatment is going to be down the when you're done. So I know that you guys don't do this, but maybe providing or sharing these techniques with nurses would be great. So this is just some type of spacers that we have, different kinds. I mean, there's so many different kinds on the market right now. But it's just so you guys can see. And then actually they have one here that somebody made it out of the water bottle. So, it's that doesn't have to be anything special. It's just when you use the inhaler straight and you puff in your mouth, most of the medication end up in you on your tongue and in your mouth and not go down to your lungs. Even though we all know, like, we come across patients that they tell us like they have a technique down, they can do that in no problem. But when they did studies and observe some of these patients, that's not the case. So just want to highlight that. All right, Amanda, I think it's you again.
Okay, this is me, and I got these really cute little baby position slides from our CF, which is Cystic Fibrosis Educator Coordinator. So each time we do CPT, we really want to make sure that we're focusing on each area of the lungs. There is a caveat to when a patient has a breathing tube in, but we'll get to that in a second. But what we tend to do is 3 to 5 minutes on each area of the lungs. And so we want to make sure that we get the front of the lungs of both the upper and lower or upper lobes in the front and the back. And then we want to go ahead and hopefully baby can be sitting up for some of these, but I know that's not always the case. With bigger kids and stuff, you can have them sitting up as well if they are not intubated. And then you want to make sure you get your upper lobes, your middle lobes, your lower lobes. And number 6 is always one of my very favorites to do because you get to lift their little arm and do that whole side area there. And I feel like with the kiddo on their side and really working those sides, we really got a lot of stuff up. But if you're doing really quality CPT hand chest physiotherapy, it is going to take 30 to 40 minutes, especially with the repositioning in between. So, some of the caveats for CPT positioning is if your patient has a breathing tube in, if they're intubated, we try to do the same positions if we can. Sometimes those are not always feasible, but we do the best we can. Sometimes we have the babies come back and they have their open chest or open abdomen, and you can't really flip them on their belly or do anything, but we do take care to do their sides really well and do the front really well. And if we can roll them to the side and get half of the back at a time, we try to do that as well. Sometimes with traction, you can't really roll the baby around at all. And part of the thing we do with this is we really work with the nurses to make sure that the airway is pretty secure and patent while we're doing this and moving the baby around. What we have on the screen too, there's a tan little um, chest bopper. I can't remember what they're called. But there's a blue one, which is for bigger kids, and there is or the blue one for littler kids, and the tan one is for bigger kids. And those really keep your hand from kind of getting tired and kind of make that cupping so you get the vibration for you. So it really does help with how tired your hands get. You always want to make sure that you're ready to suction after. And also, if the patient is not getting adequate CPT, you can always consider a different modality like cough assist or IPV or vest.
Well, this baby in this picture tolerates this pretty good.
The
Seems
baby
like
loves it.
the baby loves it. And from my experience working with uh, uh, babies with CPT, most of the babies like it, like doing a when we do CPT on them.
They really
I
do.
don't know. Yeah. Is anybody on the group that can share? Are you guys doing some CPT to neonates like this, small, or and what's your experience?
Uh,
Young, do you?
Okay, so oh, Connie is asking about pre-medicating. And she said in PT we pre-medicate the baby for pain 30 minutes before treatment. Is that our best practice as well?
For babies, usually, if we need to, but most of the time, like we don't. I don't feel like we don't have to do that because ki babies, if they're not on a vent and ICU, if we're just talking about, CF patients, usually they tolerate it pretty good. Wouldn't you agree with me, Amanda? Or
Oh,
Yeah, I would, huh?
sorry, I didn't mean babies.
Oh, any
Because
patient?
Admir was talking earlier about having that medication before CPT. Sorry.
Oh,
oh,
that is for, yeah, our mucolytics.
Yeah.
As long as they're given, at least 10 minutes before the um the CPT is started, you're probably okay because the way the mucolytics work is they break the mucus down pretty quickly, almost kind of on contact, and you really want to get working on them fairly quickly. That way, they're not just sitting there with all this thin mucus and no way to bring it forward. Does that
yeah.
make, yeah, good? For pain meds, though, for the little kids, I would say even the intubated babies with pain meds, we I would say pain meds we give a little bit more, but we also have the goal of getting them off the ventilator. And so we tried to not do and so much that they're sedated. Um, and I would say more of the respiratory type kids don't need the pain medicine more as the post-surgery or traumatic kids.
I agree. The only other thing I wanted to add is this cups, the blue and tan. It makes a huge difference. It makes a huge difference for your hand because you kind of put them between the fingers and you hold them, and then when you do it, you feel there's a better percussion to the patient's chest instead of when you do it with your hand. So sometimes if we don't have one, we'll take mask like from embu mask, um, and then just tape the hole on the mask. And we should have put that picture. I just remember like
Yeah.
yeah. Um, but we can share that with you. We use the mask and just the tape the top of the mask and use that as a percussion cup, and it works pretty good.
And I think it not only benefits the patient, but it benefits us. With those bigger patients and bigger kids, our hands always get pretty sore. Mine always did anyways, and turned red. And so those little cups are really great saving grace. So,
Yeah. Another thing when we on the same subject, the CPT hand CPT, it really went out of favor, I guess, on adult side. So on adult side, we almost never do it anymore. It's mostly some of these other devices that we'll show you here in a little bit that we use different devices, but not like hand CPT anymore because it's just if you have I don't know, 10 patients, 15 patients throughout the day and you do NCPT, like if your effectiveness of your percussion is probably, you know, getting worse throughout the day. Like maybe in the morning, the first patient gets a really good treatment, but then the third or fifth or 15th patient down the road may not get the same effective treatment. So that's why when I introduce you to some of these other devices that patient will get the same benefit every time they do it.
And is there an age limit at all to the CPT, or can you do it on a 2-week-old?
Oh, you can do it. They do it on the neonates even.
Great.
Yeah. And then, yeah, like Admir said, it's kind of fallen out of favor for the adults, but we still do it a lot on the pediatric side.
And then how old a baby can use the cough assist?
So the cough assist is usually, well, we're actually in the market right now for some new ones. And one cough assist person said it was 30 pounds, which 30 pounds or greater, which is really big. And our other cough assist that we're looking at said no limit. And we don't typically use the cough assist in the neonates, but we do use it in the PICU on the little babies. It's more of what pressure that they can tolerate. We'll usually start at a lower pressure with the babies and then work our way up to what they tolerate.
Yeah, I agree with Amanda. I think it's really pressure than anything else. Thank you for questions. Any other questions? Okay. All right. First device that it's called TheraPep. Um, it's probably our first go-to therapy that we go, and we like it. There's a couple different reasons why, but like we train the patient how to use it, and then patients actually take this home and they continue with the therapy. The way it works, it's really simple. Um, this is a mouthpiece, um, but we all can also do it with the mask. So if we just take this mouthpiece off, we can put it on the mask and patient, like some of the neurological patients, stroke patients, or some patients that can't follow command and can close their lips. So we would use a mask. Um, and then over here on this, Amanda, can you see my mouse pointer? Yeah. So, and then over here, you can see the numbers. These numbers are resistance. So you can dial in resistance appropriate for the patient. Um, so 1 would be the hardest and 6 would be the easiest. So usually, um, every therapist has a little bit different technique, but most of us start in the middle and see, if it's too hard or too easy for patient, and then you adjust it. You adjust the resistance based on that. And once you figure out the resistance, then you proceed with patient will take a deep breath and blow through it. When they blow through this mouthpiece here, um, if you can see it, but there's this blue a ring will come up, and we teach the patients to keep it between these two lines. What this does, it trains them to hold constant pressure. But also when they hold it between these two lines and keep this constant pressure, also some of the vibration gets transmitted down into their lungs, and kind of helps the um, secretions and the cilia start working and start bringing the secretion up. Um, so we usually do 3 sets of 10. So we'll do 10, take a quick break, reassess the patient, and if they're doing okay, then usually you do half cough. Half cough, we'll have a couple slides about that too. We'll talk about it a little bit later. Um, and then cough. So it's really important that after 10 patients cough, because um, the idea is like when you did 10, all these vibrations and all the movement of mucus, it it was coming up. So you want patient to cough. And then you repeat that 3 times. So 3 sets of 10, 3 sets of 10 on this. I have video, and let me see if I can. Okay. Try to share it.
Is a positive expiratory pressure device
Can you hear it? Is it good?
used to assist with chronic sputum retention and lung ventilation. It is for single patient use only. It should be prescribed by a healthcare professional trained in the use of this device. The TheraPep consists of 5 pieces: the expiratory pressure indicator for visual feedback of expiratory pressures, plastic tubing connecting the device to the pressure indicator, a valved resistor with a pressure dial, a mouthpiece, and an adapter. Assemble the device by attaching the mouthpiece to the adapter and the adapter to the resistor, ensuring that the arrow points towards the mouth. Connect the plastic tubing to the resistor and to the pressure indicator. If bronchodilators have been prescribed, administer them before commencing treatment with this device. Set the resistor dial so that the appropriate number is opposite the arrow. During the teaching session, this setting will be adjusted to provide a positive expiratory pressure of 10 to 20 centimetres of water pressure between the 2 black arrows with good expiratory flow. Sit with the elbows supported with a neutral lumbar spine and the shoulders and neck relaxed. Make a tight seal around the mouthpiece with the mouth. Breathe in with a slightly larger than normal breath, relaxing the neck and shoulders as much as possible. Breathe out actively but not forcefully through the mouthpiece with no airflow through the nose. A nose clip may be required for the initial training of this device. During the breath out, keep the top of the blue marker between the lines on the pressure indicator. If the blue marker does not sit between the 2 black arrows, either the breathing technique or the pressure dial may need adjusting until appropriate pressures are achieved with good expiratory flow. Repeat for 5 to 10 breaths depending on the clinical symptoms. Remove the mouthpiece and breathe quietly for a few breaths. This is 1 cycle. The physiotherapist will prescribe the appropriate number of breaths and cycles depending on the clinical symptoms. When using this device for airway clearance, huff as instructed by the physiotherapist, either at the end of each cycle or at the completion of all of the cycles. This should be individualised to the patient's needs. If prescribed, a nebulizer may be attached to the
All right.
TheraPep by connecting the small volume nebulizer.
Let's go back here. All right, we're back here. All right. So that's our first device, our go-to. We just like it because it's so easy to use and so portable. All right, the next device, it's called Aerobica. This device does a similar thing with what our previous device, what our PEP does, but this one actually makes a true oscillation when you blow through the resistor. And then same thing, there's a place that you can adjust the resistance. And I wanted to show you, let's see here. If you have any questions, please let me know. I'm gonna stop sharing this. And I'll share the screen.
replace it immediately. Put
Can you
the
hear it?
mouthpiece in your mouth, closing your lips around it, forming a good seal. Make sure your hand does not block the exhalation path on the back of the device. With your lips still sealed around the mouthpiece, inhale deeply, then hold your breath for 2 to 3 seconds before exhaling actively but not forcefully through the device. Active exhalation.
I just want to pause for a second, and if you can pay attention to when the patient blows through it, like to hear the oscillation, like it truly oscillates. And I tried doing this, and you really at the end of it, yeah, I'll make you cough for sure.
Should last 3 to 4 actively but not forcefully through the device. Active exhalation should last 3 to 4 times longer than inhalation. Keep your cheeks flat and firm for the most effective treatment. Continue taking deep breaths and long exhalations for 10 to 20 breaths, or as instructed by your healthcare professional, after which you will perform 2 to 3 huff coughs to clear your airways. Your healthcare professional will instruct you on the proper huff cough technique. Continue this cycle for 10 to 20 minutes, or again as prescribed by your healthcare professional. Treatments should be performed twice each day and increased to 3 to 4 times per day if your coughing produces a lot of mucus. If you feel dizzy or lightheaded, or if you have any discomfort, stop your treatment and contact your healthcare provider. Your Aerobica oscillating PEP therapy system can also be combined with your nebulizer treatment.
Okay, let's reshare again. For this device, it goes the same. Like it's portable. We like it. It's portable. It's reusable. We teach the patient in the hospital how to do it, and they take it home and they can keep reusing it. They basically just can wash it at home, with just mild soap and warm water, and then air dry it and keep reusing it. And it's really effective.
We recommend the use of the air.
All right. Any questions about these two devices? All right. Our next, so we started with kind of with slow, easy treatment and kind of ramping it up. What patient needs and what condition of the patient is. So this is our vest therapy. Some of you guys were able to see it like last time came here. We tried it on a couple of the doctors, and it was fun. Especially to have them sing when you have this on. And we do it with kids, and kids love it because it just sounds like constantly. So it works great for our kids to encourage them to use it. As we all know, getting kids to participate in the therapy, it's really hard. It's really difficult, especially we talk about really sick kids. So whatever we can do to encourage them to actually do this therapy, and Amanda will share some stuff later too, some of the cool stuff. But Vest is something that we have them sing, and for them it's hilarious. Some of the patients, same thing. This device can be used in the hospital, but also can be used outside at home. I know some people use it like on camping trips. So the best here is usually something that they use it at home, and the wrap is something that we use in the hospital because the cost. The wrap is 2-3 times probably cheaper than the actual vest because we use it for just for the patient in the hospital, and when they get discharged, we usually recycle this. So I have video for this. I want to show you.
In mobilizing retained secretions for patients suffering from both acute and chronic respiratory conditions.
This is the wrap in
This
in the
tutorial
hospital.
program is designed to give you an overview of the features and functionality of the VEST airway clearance system, including basic setup, use, and maintenance of the device. For further information, please refer to your Model 205 user manual or visit hillrom.com. The VEST system is mostly comprised of three major components: the air pulse generator, a pair of connector hoses, or a wrap garment style. Both are fully adjustable for optimal patient comfort. The hoses connect the garment to the air pulse generator and are also available in a disposable option for treatment of patients with infectious conditions. The air pulse generator displays therapy settings and remaining treatment time and is programmable for customized treatments. When they come together, they deliver a specialized type of airway clearance therapy known as high-frequency chest wall oscillation. Through rapid inflation and deflation of the garment, the chest wall is gently compressed and released, which creates airflow within the lungs. This process moves mucus toward the large airways, where it can be cleared by coughing or suctioning. The VEST system is prescribed for a wide and rapidly growing number of diagnoses. Treatment indications include secretion retention associated with impaired ventilation and/or gas exchange, ineffective cough or secretion clearance due to immobility or muscle weakness, and airway clearance dysfunction resulting in thick, sticky mucus. The VEST system is proven to be effective in the delivery of consistent airway clearance therapy for the treatment of these conditions. For full indications and contraindications for the VEST system, please refer to rests on a mobile stand with 4 locking caster wheels anywhere the air pulse generator goes. To fit the wrap vest, roll the patient onto their side and slide the disposable vest under the patient just below their arms. Roll the patient back and pull both ends of the wrap vest around the patient's chest. Attach the ends of the wrap vest so it fits close to the body and can still be comfortable. A flat hand should fit between the body and the deflated vest. The disposable wrap vest reduces the risk of cross-contamination and is particularly effective in treating post-surgical patients, mechanically ventilated patients, or patients with body types that make fitting a garment challenging. To fit the full disposable vest, position the garment behind the patient and attach the shoulder straps to the front. Adjust the shoulder straps so the bottom edge of the full vest is at the top of the patient's hip. A closed fist should be able to fit between the patient's chest and the deflated vest. Next, make the hose connections between the air pulse generator and the vest garment. Push one end of each hose into the connector ports using a slight twisting motion. For the disposable wrap vest, pull up the tab and push one end of each air hose into the hose slits. Insert approximately 2 inches. If necessary, secure the air hoses to the side of the wrap vest with the attached loop. For the disposable full vest, push the other end of each air hose over the full vest air hose ports, using a slight twisting motion to help keep them in position. Please note, it's very important to make sure all hose connections between the garment and pulse generator are set and secure before initiating therapy. Failure to do so could result in serious damage to the equipment. When the vest airway clearance system is first plugged in, or starts, use the normal mode. To do so, simply press the up arrow button above Normal. The display will then show the 3 key therapy settings last used on the device: frequency, pressure, and treatment time.
This is the reason.
All right.
Say too, in the hospital setting, we tend to really love the wrap because it's so easy to slip underneath patients rather than putting on the whole entire full vest.
Canceled my doorbell camera
Oh,
subscription.
and then
This brand new subscription free.
All right, there we go.
also a lot of our patients have ports, and so the wrap does not affect the port. And especially our ICU patients, they have so many lines in their breathing tube and ECMO cannulas, anything that is, lines, tubes, anything in the body there. So the wrap is really nice and easy to kind of get under the patient.
Yeah. We use it for non-intubated and intubated patients. And I think, like Amanda was saying, the wrap is really nice because you can just easily just slip it underneath the patient. All right. Do we have any questions about vest therapy?
Is vest available in Thailand?
I was told, yes, it is, but they're still waiting for them to provide me uh, how to get it, like provide me information on how to get it. But because I was told that it's available in Japan as well, so they were just finding appropriate people to contact for that. So, and the people I was talking to, they're working on that. So, but this one is really easy because it's kind of hands off, and you can dial in pressures, and then I was gonna my next slide here. I'll show you um, as example of a typical treatment.
So there's a question about how we choose the settings for children.
Hmm. So we usually do 3 sets or 3 or 4 sets per patient. Usually start pretty low, and the biggest one that is the hertz, and how fast it vibrates, and then the pressure. So we'll start on that, and if it's too easy, then we're gonna start ramping it up. 5 minutes on one pressure, and to see how the patient is doing. If they can tolerate, we'll go maybe a couple points higher to 10, 8, whatever the number might be, and then slowly kind of climb up. And then after a couple times, we see that patient, we'll have a good idea kind of what our treatment plan it will be for the hospital stay. But the goal always is start slow, and then especially when we have a kids that using it for the first time, we don't want to start too harsh, too strong, and then they start hating the vest and they don't want to do it at all. So we start slow, start have them sing it, and then we go from there.
Some of the contraindications for the vest can be high ICPs or head injury, because it can actually elevate the ICPs more, and also trauma. Any like broken ribs or anything like that, we tend to not do vest for. If the wrap is going to impede a chest tube, we won't do it. Um,
Port,
Ports, but usually on the bigger kids, I would say the port is high enough for the wrap.
yeah.
Some of the kids will leave if they have their whole vest, they'll leave that little side open that their port is. Um, And so we also here at OHSU, we partner with another hospital that does a lot of back surgeries, and they do like magic rods, which helps straighten scoliosis. And we tend to not do vest on them initially, but believe it or not, they tend to tolerate the vest pretty quickly after surgery.
Yeah. Even though sometimes it looks uncomfortable, but the vibrations are so fine that it doesn't really hurt. I think just that initial part, but it does when you put the wrap, it inflates. I think that that's something that could be, you can tell right away if a patient is not tolerating, but the vibrating it's actually fine. They tolerate that pretty good. And I just want to remind everybody that this goes same process as we talked about the other two devices that we use. So with, with the vest, you still do the medication first. Um, do 5 minutes of vest therapy and do half coughing. Do another 5 minutes, um, half cough, and then vest again. So, and then we have some patients that do 5, 6, 7 cycles, and they have if they use it at home, they bring their home machine in the hospital, and we usually work with them and figure out like what works for them. Sometimes in the hospital we have to adjust it a little bit because they're in the hospital because they're sicker, but we tend to kind of work around what the home settings are. Any other questions?
Oh, here come the questions. Do we need to form postural drainage while using vest, or is any position acceptable? So we tend to like to have them sitting straight up if they can. If it's like a bronchiectasis kid or a cystic fibrosis patient, we like to have them sitting up in bed. With ICU patients who have breathing tubes, if as long as they have clear spines, we'll have them sit at least 30 degrees at the head of bed elevated. Postural drainage, I've never actually done postural drainage on vest. Have you, Admir?
No. I think the biggest thing with vest, if you have somebody laying head down and then you shake him, it's gonna be really difficult to breathe for a normal person. That you don't, if you even don't have any issues. So if you have somebody whose lungs are compromised, and then you shake him and then you put the head down, um, they're probably not gonna tolerate that treatment as good. So we rather sit them upright and go through the process of do the best for 5 minutes, the half cough, and half cough. It's something that help bring up the secretions to the larger airways and make it easier to cough it up.
So, two questions that kind of tie in together. How long should I use vest therapy for to move secretions into the large airway? And why do we use a different frequency in each cycle? So, we use the different frequency on each cycle because that actually is part of what moves the secretions into the large airway. So, and that is why we huff cough in between. So I like to think of it as the secretions on the outside of the lung and the lower hurts. We're kind of just shaking a little bit. And so it's kind of moving the secretions in. And then you kind of huff and get that air moving. And then you turn the hurts up a little bit. And so you need a little higher hertz to get into the lungs deeper, which is bringing it towards the large airways. Does that make sense, I hope? Which position is the most effective or recommended to use the vest in a patient who got a chest operation? Example, a cabbage. Um, Let's see. I haven't done a vest on a cabbage in a long time. Um, Probably sitting straight up. If they can sit up in bed, your position for a patient who just got a cabbage is sitting straight up, but you would want to make sure that their chest tubes and everything were maybe pulled or were not kinking while you're in the vest. But sitting up is always best for vest. Ooh, that rhymed.
No, that's a really good question, and
Yeah.
actually, what I want to say is that that's the reason why we have all these different therapies that we can maybe vest is perfect for certain patient population, but a cabbage, for example, I wouldn't recommend using a vest on cabbage. I probably rather use the other two previous devices that we use. PEP be really effective, or if the patient has secretions, then probably I step it up to aerobica. Um, but vest, I wouldn't use it for this patient. So I think it's just all these tools. Um, you're kind of looking at the patient and figuring out like which tool would work best for certain patient. That's the reason why we have all this different devices, and because there's never one device that solves the problem for everybody. So I think that's just I hope that answers your question. But if you had only vest and you want to use it on a cabbage patient, I would like agree with Amanda. I would have the patient sit up and do that.
These are all really great questions. Thank you so much.
All right. All right. Next one. So this is our I think that we talked about it earlier in the beginning of our IPV treatments. So there's basically two main devices currently on the market right now. There's something called Metinab and then IPV. I just put a couple pictures here so to show you that the, these devices are really cool because you can use them on different setups. So you can use them with mouthpiece. But for this one, for the mouthpiece, you have to have a patient that's able to follow commands and actually breathe through the mouth. Um, Mask over here is we mostly use it on neurologically impaired patients, strokes, or some traumas that either they can close their lips around the mouthpiece or they're just not able to follow commands. So we would put the mask on and coach them through it as much as possible. Um, and then we can also use it on trach patients. So if you trached and need help getting secretions up, you can use that through that as well. I don't have a picture here, but you can use it on a ventilated patient. So if you have a patient on a ventilator, you can use IPV for that. So I'm gonna try to show you two different setups. Okay, hopefully this works. So this first video I'll show you, so two main things for IPV. There's a version that you'll secretion clearance to truly go down, vibrate inside the lungs and get the secretions out. And then also we can use it just to open up the lungs. So if you have a bad X-ray and we have a bite out and only half of the lungs are collapsed because of the mucus plugging, or so we can we use this device to open up the lungs. So this first one is secretion clearance. All right, so here's the setup. So, but they did in this scenario, in this balloon down here, they just put some liquid, viscous liquid, to mimic secretions, and so you can kind of visualize how this device actually, with the vibration and something that branded or trademark for this, it's called laminar flow. Like when flow goes in through the middle of the tube and it comes back, comes on the side, so it kind of picks up that the secretions and brings it up towards the device. So yeah, you saw like how that that the viscous solution was kind of moving towards the device, and then same thing. We would do it for a couple minutes, and we see there's stuff in a tube. We would go down with suction and suction that out. Okay, and then I want to show you my other quick video. So this next video, this IPV is tested on rabbit lungs and pig lungs. So mimicking neonatal lungs and adult patient lungs. So that's the beauty of some of these devices, that you can change it, you can use it, and we use it on the neonates actually, and then we use it on 600-pound patient. So you just it's that good. Okay.
Okay, this is just CPAP of 5 with no spontaneous breathing. You can see how slow it really does anything with the baby.
This is rabbit lungs.
The lungs, unless the baby's breathing, you're not going to see anything out of the lungs. With the IPV, and you can see the nice brown. The nice brown is airway recruitment. And this is what it looks like. I'm going to go up on the peak now to help increase the residual capacity, and you can see how the lungs are expanding. Going up on the peak. And if we let this run for the full 15 minutes, we would see this part recruit. That's the cool thing. That's my baby went through there.
I know, it's kind of amazing. It's like,
And you can increase the mean airway pressure to, the mean airway pressure is 11. 12, 14, 15, and 17. I don't want to give my brand new rabbit a pneumo. So there's a mean airway pressure of 19, and that's what the lungs are going to look like with a map of 19. Super cool, huh? So the cool thing is I could take it off of this. We got a mean airway pressure of 19, and I put it on the pig lung.
So this was just mimicking neonatal lung, and I hope you were able to see, how slowly the lungs got bigger and bigger, so it recruited more and more lung, so there's more and more air in the lung. So so he's gonna try to basically use the same setting on the machine on the pig lung.
Lungs, which are essentially the same size as an adult. And you can see how much we're recruiting, even though we have it on neonatal settings. And again, for you guys, by the way, one thing I didn't say, could you make sure, Karen, that we make sure nobody occludes this?
Oh, wow. Oh, wow. Oh, wow.
This is the exhalation. I know, blow it out.
Doesn't say that.
I saw her take 2 steps back and look at it. Yeah. Something out of a horror movie. Some places, that's why they cut this on here. They use this. It does the same thing. They use this to flush everything and recruit the airways. You don't want to do that on a baby. You only have 10 cc's. You know? Yeah, I like that. So cool. What other questions do you guys have? You guys want to try anything? Play with it while it's here?
Okay.
Okay.
I could have used that ring last.
All right, what do you guys think about that? I think that was pretty cool, and Bo, Amanda, and myself, we can all have the stories that using this device on a patient that had a really bad X-ray, white out, one side or part of the lung, and needed a lot of oxygen, and then working with some of these devices actually opens up um, and improve the patient quality of life and probably discharge them from the hospital sooner.
So amazing. Amir, may I ask,
Yeah.
how can we use this device to the COVID patient? Because we have only one, but the COVID is contagious. So how can we sterilize or sterilize the equipment?
Yeah, that's a really good question. So what we've been doing, so the circuit here, this device is per one patient. So this disposable. So one patient gets this whole thing. So that stays in the patient's room. So this blue tubing here, what we do, we put a filter at the end to filter all the particles if the patient coughs or gets aerosolized during the treatment. So that reduces the COVID particles or COVID to spread out throughout the room. And then for the actual machine, we just wipe it down with we have Oxivir wipes, but some kind of cleaning wipes, alcohol wipes or something, to wipe it down, and we can reuse it in another patient room. I was just gonna add some the one thing that this device currently is in hospital only. I know there's a couple devices out there that working on having something like this at home. But currently, this device you can use it only in a hospital, which kind of makes sense because if you're using this, the patient is pretty busy, pretty sick, and it needs a lot of attention. So, but we always get asked from our patients like if they can use this at home, and most of these devices they run from the wall, the 50 psi pressure. I'm not sure, Amanda, if you know the new one. Is there still 50 psi?
30 to 50, yeah.
Yeah, 50 psi.
Yeah.
So, and only 50 psi, you can get that in the hospital.
And then I was going to say too, we actually only have like 10 of these or something, and we share them between patients all the time. So we keep the disposable part that's for the patient in a patient-specific bag and leave that part in the room and then do a really good cleaning before the next patient. We actually will drag it around with us all day sometimes. So they're pretty easy to share between patients.
Yeah.
And then there was another question in the chat, Admir. Can we use vest on pregnant patient?
Hmm.
I would say yes
Yeah.
until the doctor says you can't, right?
Yeah. Yeah. I don't think there will be a contraindication. It's not a contraindication. So you'll be able to, yes.
Mm-hmm.
Yes, you can. Yes, you can. Um, any other questions? I hope I answered your questions, Sheila.
Yes, I have one question. Uh, we can use the IPV in ARDS patient safely. You can treat inpatient ARDS.
Yeah. Yeah. Yeah, ARDS patients, yes, you can. So one of the biggest difference between these two devices, because IPV will not lose, like if the will not lose pressure. So if you patient as a ARDS, right, on a ventilator, so usually the pressures on the ventilators are pretty high. So if you have IPV in line, it's not gonna lose pressure. So it'll still work, and it'll be beneficial for that patient.
Okay. But if I use in the ARDS patient, so if for the safely in is not induce intrapulmonary swing, right?
I don't know. What do you mean?
Because I afraid to induce when I use the IPV and induce intrapulmonary swing.
Yeah, the only problem I can see, and Amanda, let me jump in if you have any other ideas. The only concern I would have, if you have to disconnect and connect the patient with ARTS if they're on a ventilator, and to lose pressure, because usually ARDS means like really stiff lungs. That's why patient can breathe, and then the pressures on the ventilator will be pretty high to deliver volume for the patient. So once you disconnect the ventilator, patient would basically lungs would deflate, and it would be really difficult to get the pressure back up. So, but these devices, they have a little, it's called T-piece. You put it in the circuit, in the ventilator circuit, and you don't have to disconnect. You just put it in, and it works right away. So
There's a one-way valve in the T-piece, and you can put the IPV directly in the T-piece, and then that way you're not losing any of your PEEP or your high ventilator settings. Is that what you were meaning?
are you talking about the ventilated patient on the ventilator, or not ventilated patients?
So, Amir, you mean that the ventilated patient on ventilator, we no need for us to disconnect the ventilator when we use this one?
Yep. Yep.
Yeah, it comes with a T-piece that you would add to the ventilator circuit with the one-way valve on it. So you would add it in as you're setting up your ventilator if you think your patient might need IPV while they're on the ventilator. And then that way you don't lose your ventilator settings to have to disconnect and reconnect all the time.
So, in my opinion, I think this one is very useful or beneficial to the older patients because for older patients, there's osteoporosis of the rib. So it's very harmful if we do percussion. So this one is simulate or imitate the percussion therapy from the PT.
Oh yeah,
Yeah.
yeah,
And
definitely.
the tricky part with older patients, though, I will say, is they tend to be a little more sensitive to the higher pressures. So I usually would start them on really low settings to start with and just kind of talk them through how they're going to feel about it and how it works and breathe in and out with it. And then that way you can kind of slowly turn it up to get the therapeutic level that you need. Um, and then Admir has the picture here of the patient with the mask, and that is actually very helpful to have the mask that kind of straps on because then the patient isn't worried about their lips not sealing. And also, it's good for our backs because we're not holding a mask on their face. So we have to work for a long time, right? And we got to have our backs be healthy.
Yeah, exactly. Another thing with this device is that I think we mentioned it before, but just highlighting that the pressure and the settings you can adjust it. So I think that from a previous question, as like maybe the ARDS patient may needs different pressure than like COPD or some other patient that some older patient that had a stroke or something. So that's the beauty with some of these devices that that you can actually adjust it and I can really tell you like okay if this patient put this pressure this patient you know you got to use I don't know pressure 20 and this patient 25 you just go in there and usually we like to say start lower and then kind of build as patient gets used to that therapy they can tolerate higher pressure um, what we learned is that when we started using this if you just start high and patient decides that they don't like it good luck they're not going to use it doesn't matter what you try.
Can we use this one to the post-trauma patient who have lung contusion?
Yes, absolutely. In trauma, currently, I think trauma and neuro ICU would probably be the biggest users of
Use it the most.
the most.
Yeah, any contraindications would be like a untreated pneumo or a head injury again is the if your patient has high ICPs. Those would be your two big contraindications.
And how about the patient with pneumothorax already drained, but still have a pneumothorax problem?
Yeah, we still use it on them all the time. Yeah, they do fine.
Yep. All right, let's go next slide. Um, Okay, next device here, the cough assist. I'm not gonna spend too much time here. I think we got still a couple more slides to go through, but I know one of you hospital has a cough assist T70 that's using it, but same thing. You can use it with the mask or mouthpiece. So this is just a couple different brands that are popular right now, and that use here. In our neighborhoods, but we have a couple of these different versions. But basically, cough assist mimics the natural cough, makes you take a deep breath in and coughs it out, and basically sucks the air out like a vacuum cleaner. All right, we talked about the huff cough, so Amanda just want to walk us through this part.
We utilize the huff cough here pretty much for every type of patient, it seems like now. Um, it started as a cystic fibrosis kind of special cough um, since I've been a respiratory therapist, but it's kind of watching them be able to get the secretions up and out. We've kind of started using it for everyone and teaching everyone how to use it. So, huff cough is a couple different levels of kind of huff coughing. And that way, you're carrying the mucus from the most outer portions of the lung into the large airway. You use just enough force to kind of loosen the mucus. And you want to try to prevent the coughing during it because coughing, you actually get collapse and some of that mucus might go backwards. We also are finding that we love huff cough with patients who have trauma or who are weaker, elderly patients who just have lost a lot of strength. The huff coughing is a really great technique to get them to be able to clear secretions on their own. And it also tends to use less energy. So with those COPD type patients, we don't see as big of a desat where their oxygen goes down while they're coughing. So we can use the huff cough for any patient that has excess mucus and frequent coughing, which we just listed a couple of our most common ones there. Also, anyone with a painful cough, so rib fractures, post operation on the abdomen or chest. And the huff cough actually works really well for spinal cord injuries as well, because you're kind of slowly retraining how to do the cough. So the huff cough, you want to sit up nice and tall, and you want to try to sit on the edge of your bed or on a chair. You want to have feet flat on the floor. You want to tilt your chin slightly up, and you try to have your patients make like a O with their mouth, like, and then you want to have them take a slow, deep breath and they're in through their nose until they're about 75% full of their lungs. And then you want to hold their breath at the top for a couple of seconds. That way the air can get behind you, the mucus. And then you want to exhale slowly but strongly. And this moves the mucus out from your smaller airways into your larger ones. And that is part of the huff. You want to repeat this 3 times and then take a couple normal breaths, 3 more times, couple normal breaths. Then you want to follow with some strong ones to move the mucus into the larger airway. We repeat these steps a couple of different times.
Thank you, Amanda. So yeah, this been shown to be really, really effective. And like Amanda said, it's part of our, doesn't matter, we do PEP, Robica, Vest, we'll follow up with huff cough. Was there a question?
Online.
Okay.
This just kind of shows an example of how to have like an older patient who has like COPD participate. So a lot of the cough actually comes from your abdominal muscles instead of having that big coughing collapse of your respiratory muscles. And so it works really well to kind of have them as they're exhaling, kind of lean forward and help contract those abdominal muscles. I would demonstrate the cough for you, but I am recovering from a respiratory situation myself, and I may end up in a coughing spiral. So, um, Okay, one of our next things we wanted to talk about with you all is how we choose which respiratory therapy to use. So some of the things that we look at is the patient condition, which is our standard way of assessment. So we're going to look and see their level of consciousness. Are they awake? Are they alert? Can they participate in doing things like the PEP or the aerobica? Or are they have decreased level of consciousness and maybe benefit from doing something like a vest? We also look at chest x-ray. We also listen to their lungs, and we look at their vitals and lab work, specifically any ABGs or VBGs. We also take into consideration any ventilator settings. Will the patient tolerate coming off the ventilator to do IPV, or should we do IPV in line with the ventilator? Is the patient on any specialty settings for the ventilator where they wouldn't tolerate doing IPV at all, and that's going to have us do a vest or hand percussion right away. We look at the type of secretions. What color are they? How thick? How sticky? Can the patient cough on their own and clear these secretions on their own? And also, is this an acute issue or a chronic issue? With the chronic issues, these patients tend to have a home regimen already. And we tend to evaluate, are they here for new respiratory symptoms, or are they here because they needed their port replaced and we're just going to carry on their home regimen while they're in the hospital? And then we also take into account very carefully about any contraindications, such as the head injury with the high ICPs, any broken ribs that may prevent us from wanting to do vest. So those are the kind of things that we look at that helps us choose which respiratory therapy modality we're going to pick.
That's an easy slide.
Yeah. So here at OHSU, we actually have what we call a pediatric or an adult bronchial hygiene protocol. And this is kind of like a flow diagram that also helps us choose the correct modality for each patient. Sometimes the doctors will order patient to be seen by respiratory, and then that's our like, hey, we trust you guys, you're free and clear. Go do what you want to do. So, excuse me. So the first thing we tend to look at for the adult one, we'll just go with the adult one. It's a little bit shorter. We'll start with does the patient have retained secretions? Yes or no? And we just follow the diagram over. If it's no, are they wanting us to assess for atelectasis? So we'll check on the chest x-ray and we'll listen to their lungs. And if it's still no, we'll say respiratory therapy not indicated. And we'll let the doctor know that we don't think they need anything at this time. If we answer yes to any of these questions, we have the next steps that we go through. And it kind of evaluates the severity of their secretion clearance or their atelectasis. So we usually start with an IS. If the IS or incentive spirometer, if the patient does that appropriately and can pull 15 cc's per kilogram, we will let the nurses handle that for us. We're just kind of too busy to do all the ISs in the hospital. And if the patient needs help and cannot do the IS on their own, we will continue IS and we will often start one of the PEPs or the aerobicas with them. And then we'll keep advancing as needed all the way from vest to IPV. So we can also choose the frequency of each therapy for our patients. So is the patient at any risk for getting atelectasis and they don't have any, we're just going to say have them do the IS, all the way up to they have a ton of secretions. They're needing suctioned on the floor quite often. We're going to go ahead and order that patient for vest or IPV for every 4 hours. And then once the patient is stabilized, we can actually start weaning them in the reverse order.
Okay, I just want to pause for a second. So, week 6:30. How many minutes do we need for the case presentation?
Let's say 20 minutes.
Okay, I think we're almost done. Okay, perfect.
Okay, then I'll just kind of speed through because this is the one everybody wants to know about, right? How do you get those babies and kids and people who don't want to do their treatment to participate? So we do a lot of kind of fun things with them. We will have, if the child will not do PEP or IS, we will bust out the bubbles or the pinwheel, and that actually does a lot of things that kind of mimic what the PEP does because they end up pursed lip breathing anyways, and it becomes kind of a fun game for them. The caveat is if you're doing bubbles, you can't let them do bubbles any other time, or the bubbles become too old and they don't want to do it with you anymore. Right, so bubbles have to be special with you and them. We also like to add stickers to the PEP. So on our PEP device, the little blue part goes up. We will put a surprise sticker on there. So as the child blows, and does the therapy correctly, the sticker will pop up, and they actually think that's hilarious. And sometimes we'll hear that the patient really likes superheroes, so we will get superhero stickers and give them a new one after every treatment. We also can do things where we make the treatments a game. Sometimes we'll put like a wad of paper in the end of the PEP and they'll try to blow it out, or we'll make like a little basketball hoop for them to blow it into. Some kids and parents only allow their iPad during the respiratory treatment. I had one kid who could only watch her favorite Mickey Mouse video during her vest. So I knew that song really well by the end of the day. And then we have the parents help us. If it's an older patient, we really try to have them participate in their treatment and let them know what the treatment is and why they're doing it. It's so easy to just get busy and say, "Here, do your treatment," and then they don't want to do it because they don't know why. So it's really important to have that good communication with them and let them know why this treatment is important.
I like the bubbles.
I like the bubbles too. That was always
Yeah.
fun.
Yeah. It works every time. Okay, well,
Oh, you froze it.
did I? What's going on?
You have it on cursor. So you keep putting your name in the red arrow.
I know, like, no way. There we go.
Yeah. Another way to encourage children or even adults to do um, participation. One of the ones that we've kind of found in recent years is to have today's schedule and treatment plan very visible to the patient. Then the patient feels like they are involved in their own care. The nurse and the parent can say, "Hey, don't forget respiratory therapy is coming at 10 o'clock. You have 30 minutes to finish your playtime." And that kind of gets them ready to know that we're coming. So really the schedule has and having it visible for everyone to see has really actually made a big difference. Um, and it also helps us because we're not showing up when the patient has time to walk with their physical therapist or is having their class time. So it really helps us as well, so we know when not to come for their treatment as well. And we are very fortunate to have child life specialists at OHSU, and these are certified specialists who help children cope with their hospital stays, especially kids who are first time in the hospital. They don't know anything, so they do a lot of medical play with these kids and kind of help teach them about how things work and why we have to do them, and we let them do it to their little stuffies. Child Life also does art supplies, and then we call them if we need more pinwheels, and we also call them if the kids want to do some games. Sometimes the kids like to play games with us while they're sitting on their vest. We'll play a card game or something. And also they bring music and stuff to them. So we're really lucky to have them.
Connie,
And,
I was gonna
oh.
say Connie's gonna love this slide.
I love this slide. Oh, if I could just learn about this all day, I would. Early mobilization on all patients, and that includes our serious illness patients. So, in the PICU, they're doing a really good job of starting early mobilization while in the ICU, and in our adult units, we are getting better. I will say we've had some barriers, some staffing challenges to make these things happen. But patients who start having mobilization happen while they're in the ICU, actually, they have reduced ICU delirium, they decrease their days on the ventilator, they decrease ICU days, and there is a study that will be, I have, what's it called, referenced, that says that some hospitals are having patients who can actually stand on discharge from the ICU, not even the hospital, from the ICU. And I just learned a saying about 2 years ago that has just really stuck in my head, and that is movement is medicine. And you have to keep moving to get better. And another thing is it prevents deep vein thrombosis, helps prevent ventilator-associated pneumonia, pressure sores, and ICU-required weakness. And early mobilization takes a team. I'm sure you guys know as well. But here we have a picture of a kiddo who has a tracheostomy, but there is the nurse, the physical therapist, and the respiratory therapist, and the kiddo is riding their tricycle while on the ventilator and while on all their IVs, and they are just so happy. And actually, I always found it really fun when the kids got to get on their tricycles. We also have a little Power Wheels car that if the kids can't quite move yet, but we can sit them in the little car and they can drive it around and push the ventilator behind. We have that as well. That we'll do sometimes. And that gets them sitting up and active to people, and so those are some of my favorite things to do.
Yeah, it just keeps them out of the room.
Yeah.
Right?
Yeah. We had one kiddo who would wear a police officer hat and ride the tricycle, and I'd push the ventilator behind him, and we'd have to stop and write tickets to all the people he saw in the hallway.
That's funny. All right. That concludes our presentation for today. Please let us know if there's any questions. But if you have any questions tomorrow, if you're like, oh, what was that about? Please, you can forward your questions to Connie, and Connie will contact us, and we will be more than happy to assist with whatever you guys need. And I hope to see you soon with Amanda. Right, Amanda?
Hey, Mr. Tan, case studies.
Okay. Yeah. Thank you, Connie, and thank you, Edmir and Amanda. Thank you so much.
Thank you. It's a pleasure.
Are you coming this year, Matt?
Probably not this year. Whatever Connie says. Connie's the boss.
Okay, I will ask Connie who's coming.
Yeah.
Admir will come 2025 with
Okay, cool.
cardiopulmonary.
Okay.
There we go.
Oh, I see your slide already. You can start now.
Okay, just a moment. Excuse me.
One more question, Amanda.
How do we manage manpower and time per patient? That's a great question. Our charting system actually has time built into our orders, so we can kind of predict how long each respiratory therapist is going to be with each patient. So we even have an order called early mobilization of a ventilator patient that gives us an allotted time. We also know that that time is not a hard and fast rule, and sometimes it takes a lot longer or a lot quicker. And then we also, for manpower, if we know that we're going to walk a ventilator patient or a patient who's on a lot of respiratory support, we will actually call PT. That that's you guys, right? We'll call PT, RT, us, the nurse, and then often the doctor will come with us. And we will all get together and look at our schedules for the day and plan, okay, we're going to go for a walk to the giant windows to look outside at 3 p.m. And we all meet there at 3 p.m. And if I have time before 3 p.m., I'm actually going to start getting everything ready in between all my other stuff.
Big thing is communication and get the whole team on the same page. And if you can communicate to all the people involved and pre-schedule it, it usually works a lot better.
Okay, Mr. Tan.
Okay, thank you very much. Yeah, today we have three cases for sharing. Case number one from BHQ. The PT who sharing, his name is Parkin Swangam. Right now he stay at Mongolia. He will share the case from over there. Okay, please sharing. Good arm.
Good morning, everyone. Good morning from Mongolia, Ulaanbaatar. Good morning, Tan Suchila, Admir, Connie, and Amanda, and everyone. Okay, so I'm a physical therapist from the critical care team at BHQ. Today, I would like to talk about our role in patients with pneumonia in ICU. So the patient is a 78-year-old Bangladeshi man who can walk independently before this illness. His medical condition include atrial fibrillation, diabetes, hypertension, coronary artery disease, dyslipidemia, benign prostatic hyperplasia, hypothyroidism, Parkinson's disease, and delirium. Here is the timelines of the patient progress from admission days until he could move to regular room. On the admission day, he presented with a fever and dyspnea due to secretion retention. His RAS score at that time was -2, and he was diagnosed with pneumonia. The problems of this patient include secretion retention, poor ventilation, and poor activity. Over the next 2 days, his RAS score remained at -2. It was on the first day that the doctor consults a physical therapist. So at the first day, the program include diaphragmatic breathing exercise, trifold, chest expansion and mobilization, secretion drainage, chest percussion, suction, coughing, and assist exercise. But however, the patient was not really cooperative. The following day, his symptoms worsened with wheezing, dyspnea, and oxygen saturation of 93%. He was intubated with an endotracheal tube in CMV mode. Physiotherapists were allowed to perform early chest program including vibration and suction. By October 9 to 2023, his condition had not improved significantly, and he had a lot of yellow secretion. Bronchoscopy reveals pus in his left lung, and the ICU nurse notified that there were a lot of secretion. So he had to be put on ECMO to provide adequate oxygenation during the procedures. Physical therapy continued with vibration and suction. By October 17, his condition started to improve while on a ventilator in CMV mode, later changed to AC mode after being taken off ECMO. Passive exercising was initiated, but weaning of the ventilator to TPs failed multiple times, leading to a tracheostomy. Post-tracheostomy on October 27, the weaning process progressed well with the addition of trilogy and multimodal hand cycling. By November 2, the patient showed good progress, being able to breathe with high flow and becoming more awake and responsive. So ambulation programs were added, including sitting on the edge of the bed, standing with two table, and finally standing with terminal. He was eventually moved to the regular ward on November 12. So totally length of stay in the ICU was 42 days. His chest X-ray. So the next slide. Yes. The chest X-ray from the first day of the consultation, the 4th of October 23, and the day his chest X-ray shows worse. The 9 October, the day he got tracheostomy, and the day after moved to the general ward. So like at the first day, it feels interstitial infiltration, and after that getting worse. So like his lung condition is not really good, but after that, after medical treatment and physical therapy, his lung is getting better, was getting better. So the next slide. So, and you can see from the table provided, the impact score has improved in our domain since the first day of assessment. The patient has been moved to the general ward and his condition is better. I heard that now he can walk 20 rounds in like general ward at it's around 55 meters for each round. So I think it's about 1 kilometer already. Yes. So at the end, could you please provide the guidance or recommendation on the proper technique for handling this case?
Hey, good job. I just had a question in the beginning. You mentioned high flow. Do you know how much flow was the patient on?
I have the information.
If you don't know, it just would tell me, if it's just 10, 15 liters versus 60, it would be a different approach, I guess, because it sounds like the patient for sets are 88 to 89, probably was a pretty high flow, I would assume, and end up being intubated.
Yes.
Yeah. The other thing, so, and it sounds like initially he got intubated mostly because of the secretions.
Yeah, the secretion and yeah, a lot of secretion because at the first time he came with a high flow with cannula, right? But the patients and relative actually they don't like to like we to do a suction or like do the physical therapist because like I think most of the patient they don't like to do suction through
Yeah.
the nasopharyngeal, right?
It's not comfortable.
It's not comfortable.
Yeah.
Yes.
Um,
So that's why because he has a lot of secretion and after that his oxygen is getting low.
Yeah, it sounds like he had a pretty bad pneumonia. So all the stuff that Amanda and myself presented earlier, like all these steps, like if I have a patient like this, I probably skip all the steps and go to IPV, straight to IPV. Like we talked about, like, do PEP, do aerobica, vest, all that. Like if I have a patient like this in ICU, I just go boom. I just go for the IPV right away because I know this patient has a lot of secretions and I need to get the secretions out somehow. And from our experience, something like that strong, something like that's really strong, it's really effective. It would works the best. So but chest percussion. I know you guys were trying to do chest percussion and suction, but that would be on a patient that maybe has, a little bit secretions, a little bit atelectasis, but this patient needs something like cough assist or, something like heart. That's what I would recommend. I don't know, Amanda, what do you think?
Yeah, I was gonna say definitely I would have gone straight to the IPV as well. And depending on how strong the patient's cough was, I may have added a cough assist to follow the IPV. Did you guys give do you know if you got any of the mucolytic breathing treatments, medications? I
Any
probably
inhaled?
would have ordered those as well, like had the nurse give those breathing medications that helps thin the secretions even more.
In here, like because the nurse will give the medication for the patients.
Yeah.
So sometimes like we like the doctor will order or tell the nurse about what time a physical therapist will come and they will give the patient medication and like
Gotcha.
With the mask.
bronchodilation.
Yeah.
Yeah, and then we talked earlier. I think that's really important to
Coordinate that.
coordinate that. It's like, okay, I'm gonna give you a treatment, and then we'll do the breathing treatment, give you medication, and then you follow up with something stronger. But I think this patient was needed a little bit more than just CPT.
This patient was sick, huh? Yeah.
This patient was sick.
Yeah, I saw that you talk about. Sorry.
No, go ahead, and then we'll go to the next one. Go ahead, fine.
Yeah. I saw like your slide talking about today's schedule. Actually, we have it in here too, but it's not really detailed like you do. So because like we have only the schedule of the rehabilitation teams, like when the times of the OT team, the neuro team, and chest PT. But like I saw your schedule, like you coordinate with the nurse to like what time like the patient have to eat and what time the medication will give and what time the physical therapist will come like that. So I think it's really interesting that like if we can do it in here.
Yeah.
Great. Okay, we need to move to the second one. I'm sorry, that was a great presentation. Thank you.
Okay, thank you very much. Yeah. Okay, next one from Pediatric 2. Who PT who trying his name is Ratsit Kitaya Singh Skun or Winnie. Or Winnie, would you like to share your slide or you can give me share for you? Okay, you give yourself. Yeah, thank you. Okay, let's go.
Hi, we are from Pediatric 2 hospitals. Okay, I'm gonna start. A 67 male with car accident on April 10, 2024. Doctor did the X-ray and found that he got a multiple lip fracture at bilateral side with light apicolateral pneumothorax about 4.4 centimeters. Doctor was diagnosed that he has right lung contusion and pneumothorax with multiple lip fracture status post right ICD tube insertion. After that, he was referred to Pediatric 2 Hospital to continue treatment. And on April 21st, 2024, doctor consult physical therapy for pulmonary rehabilitation program. His status was good consciousness and communications, no limit RM or limb, muscle weakness grade 4 plus all limb, independent mobility, balance sit and stand was normal, independent ambulation. But his respiratory status was mildly runny nose, shortness of breath with paradoxical abdominal breathing, on high flow nasal cannula 35 lit per min and FiO2 0.4. His oxygen sat was 98 to 99 and the doctor keep oxygen more than 22%. And he on ICD tube at right chest and his lung decreased basal at lateral and anterior basal of right lower lobe, but the others broncho-vesicular breathe sound, no adventitious sound, thoracic re-expansion right more than left, intolerance to control breathing in inspiratory capacity and expiratory reserve capacities.
Yes. And at my first visit, we managed about the treatment for the respiratory rehabilitations. And firstly, we use the Vita therapy in the order simulate the diaphragm movements. We use the Vita around 2 weeks, and we train the chest expansion therapy, and we correct and control in the sagittal and coronal pain chest expansions to the synchronized breathing cycle of the patient, and react and control to the synchronized abdominal movement or the diaphragm movement because the pattern breathing of the patients, he present the paradoxical abdominal breath from the car accidents and he's looking the severe breathing. And we control and correct push lip breathing for the saving energy in patients, and we add the sustained maximal inhalations and hold breath 3 seconds, and we setting target for the patient in 8 seconds. And we use the autogenic drainage for the drain secretions or the hematoma on his lung. And huffing technique and containing with us with oscillation secretion in throat technique. Yes, and it was ineffective because at the first time he unable to control force of the respiratory muscle in the expiratory reserve volume target. Yes, and the time for training in the vital capacity target. I'm setting in the vital capacity target and the upside down training in for expiratory reserve volume target, and he couldn't to do first visit day of the therapy. And this is the present his progression. And 3 days after rehabilitation, the doctor changed the high flow to be the oxygen cannula for the 5 liters per minute, and his present the oxygen saturation 98 to 99%, undergone the oxygen cannula. And during 7 days after treatment, we forgot to training on the respiratory muscle. We train the separate inspiratory muscle with the expiratory muscle. We train separate two muscle. And after therapy on day 7, doctor tried wean off the oxygen cannula, but unsuccess because his presents when he off the oxygen cannula present the oxygen saturation around 90 to 92, and the dyspnea on exertional, and he more exhausted. Yes, but he was able to do the effective of the huffing technique and the containing with the oscillation secretion in throat technique. Yes, the exactly patient can control the respiratory muscle in my setting target. Yes, and total lung capacity force, and 3 ball ups, 3 ball stops on the diaphragm training, and the 2 ball stop in the diaphragm training in upside down. And for 6-minute walk test, it was unsuccess. He could walk the 220 meters, and due to the exhaust and stop it during test because he's present the oxygen desaturation less than the 90%, and the block dyspnea scale was the X score. And after that, we add a program of the respiratory therapy after day 7 until day 40. We did the still management by the SMI technique. Yes, and he was able to hold it for my setting in the 5 seconds. And we add the lateral decubitus positions for and combine using training, diaphragm training, and he was able to do 3 ball ups and a success. And for the change motivations and prevent ball technique and ball management, we add the Tai Chi in the Chinese workout and pranayamas breathing control in the Indian. In the order promote the mobility, balance, breathing control, and the motivation. Yes, and 14 days later, his status after treatment has the no dyspnea, no exertional, normal breath sound at the lateral and anterior basal of right lung, and no oxygen desaturation, and the success of to wean the oxygen cannula. And then we take him to walk in the treadmill at the rehabilitation department for the cardiopulmonary exercise testing, because we want to know that he ready for the discharging and back home, and also he's setting goal want to back to work in the treadmill independently. So we evaluate his the cardiopulmonary fitness, followed by we use the Bush sub-maximal treadmill protocol, and we used to return the 6-minute walk test for him. And the result found that the patient is able to work treadmill at the 50% the oxygen oxygen consumption maximum, and 8% of the incline and 3 of speed. And also able to walk with the 6-minute walk test, and successfully. He can continue walk without stop 520 meters, and he present the oxygen saturations around 96 to 98%, and blood scale present the 5 score. Yes, sorry for okay.
Actually, we're out of time, so could we ask, do you have questions of them?
Yes, and when I collect the peak oxygen consumption from the 6-minute walk test, and he present the 58.17 milliliter per kilogram per minute. Yes.
What question do you have?
Yes. Okay, and my question, would you recommend to the management the respiratory muscle in your experience? Yes.
I think you did good with this patient. You started breathing exercises right in the beginning. We do the only thing that I probably would add is I would add like PEP would really work out for this patient for the chest contusion, because usually it's a little bit easier to blow through it than to inhale. And then the other suggestions I would have to when you do IS or PEP workout, like I don't know if you probably done that, but I hold a pillow when they do coughing. I know we don't have a lot of time, but and then I know this is not PT, but like the high flow, I probably wean that faster than because you were like setting 98, 99, and you were still on
Higher flow.
So we could have probably weaned the oxygen off sooner.
Yeah.
And Amanda, do you have anything?
That's the only thing I would have maybe added to was the PEP, because it looks like Admir said, when you're blowing out, that's a little bit easier for patients to do, especially when they're in pain. And then adding the pillow to help with the huff coughing, because you kind of stint all those broken ribs. Did you guys do that? Do you do that pillow?
Say pillow.
Pillow hug?
Yes, yes.
Yeah.
We collect the pillow when
Yeah.
he cough, when he
Cough.
huff. Yes.
Yeah. Okay, good.
Yes, but
But
we
I
don't
think you
have the
guys did
pet therapy.
amazing. No PEP therapy. Okay.
Yes.
Maybe pursed lip
we have
breathing,
less
like
the facility in my hospital.
you do, or you don't?
Yes. We have filled the facility about the device therapy in my hospital.
Gotcha.
Yes.
So
We
maybe you
just
could
use
do like
about
pursed lip breathing instead, like the pursed lip breathing to kind of mimic the PEP a little bit, maybe?
Oh, talking about PEP.
Oh, look, he's got one.
We adaptive for the
Look at it. This is what I got from
Uh-huh.
Thailand.
Oh, you have one from Thailand.
I have one from Thailand.
Yes, we adaptive blow the water off.
Yeah. Very good. But no, I actually thank you for sharing this. I wish that we would incorporate things like Tai Chi a little bit more and a little bit more movement. I was like, dang, I wanna come work here. This sounds awesome. Oh, good job.
I
It's
like
work
that.
good. It's work good. Yes.
Are you an instructor, Tai Chi instructor? When me and Amanda come to Thailand, you teach us some Tai Chi.
Yeah.
That sounds good.
Thank you, everyone.
Thank you, everyone. That was another great case study. Mr. Tun, can you send the third one to me? So Amanda and Admir can take a look and give some suggestions.
Okay. We follow up with Tan for that.
Okay.
Connie? Yeah. Thank you very much, everyone. It's super comprehensive again, as always.
Great presentation. Thank you, everyone.
Thank you, guys.
Thank you. It's a pleasure.
Have a good day.
Yeah, thank you,
Thank
everybody.
you, everyone.
Enjoy your day.
Yeah, I will send the third case to you. Yeah, and thank you very much.
Thank you so much.
Thank you. Bye, Jenny.
Bye, Admir. Bye, Connie.
Bye, Connie. Bye, Amir. Bye,
Bye.
Amanda.
Sawadika. Thank you, Amanda and Mir. You guys did amazing.
Thank you.
Send me your presentation and videos. Bye-bye.
Bye-bye.